Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Oxnard Health System and Humana to bring Oxnard's Hello Health weekly education and information series to you. Our topic this week, gastroesophageal reflux disease. So what causes GERD? What can we do about it, and what dangers does it pose? Our guest is gastrointestinal surgeon Dr. Tommy Delahoussaye. First, some background. Dr. Delahoussaye is a New Orleans native, a Jesuit grad. He did his undergraduate degree at LSU. His medical degree is from the LSU Health Sciences Center in New Orleans, where he completed his internship and residency in general surgery. And he has a fellowship in minimally invasive gastrointestinal surgery. He is a board-certified general surgeon and performs bariatric, intestinal, and robotic surgeries. And it is our pleasure to welcome Dr. Tommy Delahoussaye to Hello Health. Good to have you with us on the program.
Thanks for having me.
Thanks for being here. Your first time on this program, first time on television. First tell us a little bit about your family and how you first got interested in medicine.
So I grew up in Lakeview in New Orleans. My mother was a nurse, my dad's an insurance agent, but I got interested in medicine pretty much the late part of high school, early college. Just became interested in biology and wanting to help people. So became a doctor going to LSU, and then throughout medical school I really liked to perform surgeries and procedures, so then that led me to become a surgeon.
Okay.
As far as my personal life, I'm married. I have 3 little girls. Hi Ashley, hi Kate, Anna, and Elizabeth. I have a 5, a 3, and a 1-year-old, or a 7-month-old, but all doing good at home.
And a wife taking great care of them, right?
Wife taking great care of them.
All right. Well, so let's start with, what is gastroesophageal reflux disease?
So gastroesophageal reflux disease, it's a chronic disease of the lower esophageal sphincter. It is acid that continues to go up from your stomach into your lower part of your esophagus. Some people's can go even mid and upper part of the esophagus. So it's usually caused by weakness of what's called your lower esophageal sphincter, and that is where your stomach and esophagus meet. You have a dense band of muscle there that is supposed to prevent acid from going up, but when it's weak or it continues to have relaxation, then you can get what's called acid reflux or GERD, and you get a burning sensation in your chest.
So there's no flap there. We'd like to think of it as a flap. There's no flap, right?
There's no flap there. It's the technical term is a sphincter, so it's supposed to be a thick band of muscle that prevents, it's supposed to be more like a one-way valve to prevent food from coming up and allow food to come down. So it opens during your eating, but it's supposed to be just firm enough pressure to where you don't have reflux while you're sitting there.
What causes it to loosen?
So a lot of people, it can just be weakened. That's just more a personal thing. It's not anything that usually is a chronic damage. It's just people have a weak sphincter in the area. Certain foods can relax it, but as far as ways to prevent it once you have it, it's mostly losing weight and doing anything that would increase the amount of pressure on the inside of your abdomen. So obesity can increase your risk because it puts more pressure on your abdomen, and that pushes more gastric contents up into your esophagus. Some people can have other problems with their stomach or their esophagus that can cause similar symptoms to reflux, but it's usually a weakness at that sphincter, and some people have a hernia in the area of your diaphragm right there that can contribute to that.
So I know fried food is a no-no for me as far as eating fried food late. Certainly not a no-no. It's on the menu, but I try to do my best to balance that late at night. Mints, I think, peppermint is something else. What are the kinds of foods and things people should avoid who have these issues?
So fatty, spicy foods are some of the main ones. Chocolate can cause a lot of stuff. Coffee, people have their morning coffee and they can get really bad reflux. Any really acidic things, acidic juices like orange juice and those types of things can cause significant burning in the area. Now those aren't the cause of the reflux, those just increase your symptoms and the pain that you can get from having the increased gas.
You've just disappointed a lot of people because a lot of those things are staples in our diet. What are the symptoms of GERD and which are the ones we should really be concerned about?
So the basic symptoms of GERD, a lot of people get a burning sensation kind of the bottom part of their chest, upper stomach area. And that's kind of the initial symptom for a lot of people. Sometimes the first time they notice it, maybe they're laying down at night and they get a sharp pain in the middle of their chest. They sit up, take a Tums or something, it goes away, and then they notice that every time they do a certain thing, whether it's drinking alcohol, eating something maybe they shouldn't, spicy, fatty foods, they get this sensation. Now it can be a wide range of symptoms. Some people have really bad reflux. They can get like basically silent pneumonias because they get reflux that goes all the way up to the top part of their throat, and then they get some acid that goes into their lungs and causes damage. People can get hoarseness because it can cause damage to basically your larynx back there. You can feel, some people can feel like difficulty swallowing or feeling like food gets stuck in the area. And that's oftentimes, if you have a hernia in the area, you can have part of your stomach in your chest there. So that's can also be a symptom of reflux. Can cause a whole range of issues that may or may not be noticed as reflux to the patient, but then once you go over their symptoms, then it can be contributed to that.
And the sitting up versus laying down, that's just a gravity thing?
So that's a gravity thing and a pressure thing. So when you're standing up, then all gravity's forcing everything down. It's hard for acid or anything while you're standing up to go against gravity straight up. But when you lay down, then your stomach and your esophagus are basically flat with one another, and so the acid can seep up. So a lot of people's symptoms at night are significantly worse, or if they lay down or flat right after they eat a meal, it can be significantly worse.
We see more and more ads for these beds that can fold up and sit up. Is that the type of thing you would recommend for someone with GERD, or is the problem still there and creating potentially dangerous issues? The acid just isn't making its way up the esophagus?
Well, yeah, the beds, especially if your symptoms are mostly at night, those probably will help you significantly as far as getting symptoms, because it's, like I said, it's going to be hard for any liquid to go against gravity. As far as is that going to cure it, that's not necessarily going to cure the problem, but if your symptoms pretty much go away after that, then yes, that may be all you would need. Maybe you wouldn't need anything else. And then if your symptoms progressed or you had other symptoms, then you may want to look out to at least get looked.
So just that acid or churning around in the stomach creating this issue, that in itself isn't the dangerous part. The dangerous part, or potentially dangerous part, is the reflux coming back up.
Yeah, so everybody has the acid production in their stomach. So reflux is not because you have necessarily too much acid. It's because the acid's making its way to your esophagus. And so your esophagus is not supposed to be a very acidic environment. It's more of a neutral environment. So when the acid goes up there, it causes basically a chemical burn to the bottom of your esophagus, which can cause damage to your cells and can lead to bad things in the future.
Good clarification. So how do you officially diagnose someone with GERD?
So first off, it's based off of your symptoms, a lot of the symptoms that we talked about. And then most people who have the symptoms that are severe enough, we can start them on a trial of medicine called a PPI, Prilosec, Nexium. Those are all different types of it. And if after that, their symptoms completely go away during that trial, then that's part of the diagnosis that they probably have reflux. Now, that's not a confirmatory test. The other ways that we can truly confirm it, a lot of patients with those symptoms eventually will need what's called an EGD, and that's a scope, an endoscopy, where we go through the mouth and we look at the bottom of the esophagus and the stomach, and we kind of go symptoms, and we can discuss a questionnaire that goes over all the different symptoms to see if it's likely reflux or likely maybe some other intestinal or abdominal issue.
Is it something that can be controlled by diet? So we talked about some of the things you would want to stay away from, but is it the kind of thing that can be cured by diet?
So like I said, it's not necessarily a problem with the diet. You're still going to have a weakness there, so you still can have some acid coming up. Some things can make it worse or better. Fatty, spicy foods can cause more symptoms, but it's not necessarily going to cure the actual cause of the problem. If changing your diet does make your symptoms completely go away, then maybe you're one of the few that responded great and probably lost some weight during changing your diet, so maybe that contributed to the decreased reflux. And you know, the elevation of the bed we talk about, the dietary changes, the smoking. Smoking can cause trouble with everything, but especially with this, it can cause a lot of stuff. And another thing, I guess, kind of correlate, I didn't mention it earlier, the abdominal pressure. So women, when they get pregnant, a lot of them get reflux, and then it goes away when they're not. So that just shows that it's a lot of it's pressure, and that's pressure while you're pregnant, pushing up, causing your reflux. After you don't have your pregnancy anymore, you don't have a baby pushing, then your reflux can go away. You probably will never need anything if you just had reflux during your pregnancy.
So if diet restrictions don't handle it, what's the next level of treatment?
So first we try the PPI trial, which is the medicine. We see if you respond to that. We make sure that we do an appropriate length of time. Some people it's 4, some people it's 8 weeks, to see if you respond. And then we try to take you off of that. You don't want to be taking that your whole life. You want to see if it helps, and if it does help, and then when you get off of it, your symptoms come back just as severe as they were before, then you would need to be evaluated to see if you needed any further treatment to figure out what the problem is.
Can some of those medications actually cure the problem? So you mentioned if you get off of them, it might come back. In some cases, is it possible that just the medication could repair that weakness?
So it's not going to repair the weakness. It maybe will show us that you have reflux, and the way that those medicines work, it just decreases your acid production by about 90–95%. So you still can have the reflux, it just doesn't hurt because there's not as much acid in it. So you still are getting the fluid coming up, but the fluid is no longer as acidic, so it doesn't hurt as much as it did before. It may not hurt at all because you don't really have much acid causing, like I talked about, the burning sensation in your chest.
But acid is obviously doing something, helping break down what we're eating. So reducing that acid, is that creating other issues?
So some people can complain of, while being on PPIs, multiple GI symptoms. Now most people tolerate them pretty well. Some people can get bloating, diarrhea, a lot of different things, and usually not major intestinal issues, but can get some GI discomfort.
So something to look out for if you are on these medications.
Yeah, and there's been a lot of stuff now to say there's certain things to look for. You don't want to be on this long term unless there's other contraindications being worked up. You don't want to just stay on a medicine forever that's not really fixing something, it's just kind of hiding the problem.
You talked about an EGD earlier, so talk to us exactly what that visit would look like and how the process works.
So normally you'd see either a gastroenterologist or, if you came to see a surgeon first because you said, I have this, I want to be evaluated. So surgeons or gastroenterologists usually are the ones that are going to be doing the endoscopies. You get set up, basically it's an outpatient procedure. You just don't eat or drink anything before midnight the night before. It's not like a colonoscopy where you have to drink a big prep and clear out your intestines completely. So you come in the morning, you get sedation, we put the scope through your mouth, look at your esophagus all the way down and into your stomach, and then the first part of your small intestine or your duodenum, we evaluate to see if you have any gastric ulcers, gastric polyps, so those are like stomach problems. And then we look at the lower esophageal sphincter to see if you have chronic damage. We also check to see if you have a hiatal hernia or like a big opening in the area there. And those are all things that we look at to see if, yes, you have reflux that's causing damage, yes, you have a hernia that may need to be fixed, or if we don't really find anything, then we may just do a further workup to see if there's other issues.
Make me feel more comfortable about the tube you're getting ready to shove down my throat.
So you will be sedated, so you will not be awake while it's going down.
I'm awake, but I'm not there.
Yeah,
right?
you're awake and your eyes are closed, but you don't have to have like the tube into your lungs where you're intubated. It's like a sedation, so you won't remember anything that happened. And you wake up and go home 30 minutes, an hour
Most people
from now.
tolerate it pretty well.
Most people do fine with the EGDs. It's not painful afterwards. We take all the air out of the stomach, and so most people, an hour after it's done, they're like, where can I go eat? They want to just go eat something because they're hungry from not eating the night before.
There you go. Our guest this week is Dr. Tommy Delahoussaye, and we're talking about GERD, gastroesophageal reflux disease. So some GERD patients will develop infections, and one in particular that I know you wanted to discuss on this program.
Yeah, so there's one bacterial infection that can cause similar symptoms to reflux. It doesn't necessarily cause reflux, but the symptoms that it causes are very similar in nature. It's called H. pylori, and so that's something during the EGD that we test for, or if you didn't get tested for that before, then there's a breath test that we can do for that as well, that we just basically have you do that. There's also a lab test that we do, a blood test. And so the H. pylori causes a lot of the ulcer symptoms in your stomach. But when you start developing ulcers, you get pain in the inside of your abdomen, and you can present as similar symptoms to reflux. And most of the time, just curing the H. pylori does not necessarily fix your reflux. You may or may not have reflux if you have H. pylori or not, but this is something that we do look for if you have similar symptoms to check for, to see if you need to be treated for that beforehand, and that's usually treated with a few antibiotics and a PPI actually, because it decreases the acid and allows the ulcers or damage that the bacteria has to heal.
Are there other tests to diagnose GERD that you're using?
So yeah, once we get to where we feel like we're pretty confident, or at least suspicious that you may have GERD, then we do some other testing. One of the testing that occasionally is done is called pH testing. This is where either a probe is placed in your esophagus, and now they have some that are like breathing tests that we can do. It's a little tube that goes in your nose, and it checks your pH usually over about a 24-hour period. We look at the results. We see how many acid reflux episodes you had. So the way that the pH works, basically the lower the pH, the more acidic something is. So we check to see how low the pH gets when we do that test, and that'll confirm or deny the fact that you did have so many low pH events. That means you're getting more acid coming up. Esophageal manometry is a test where we check the pressures and basically the movement of your esophagus. So that's a little bit uncomfortable for some people, that you're awake during that testing. It's a tube that goes usually into your nose and into your esophagus, and we have you swallow, and we watch your contractions and your relaxations while you swallow to see if you possibly had an actual esophageal motility problem, maybe not an actual reflux problem, and that would be treated differently, more with medication and other treatment options than proceeding to being treated for reflux.
Next, we're going to talk about some of the more serious complications of GERD, and we do want to warn you, some of the pictures the doctor brought along, if you're squeamish about these sort of things, you may want to listen to this part of the program as opposed to watch, but we are a medical program, so we're going to show these types of pictures. So let's talk about some of the serious complications.
So some of the this is the third, some of the serious complications that you can get is damage to the esophagus, and which leads to what's called Barrett's esophagus. Barrett's esophagus is a term we use to describe a damage to the point where we can see damage on the EGD, and it causes your cells to change from one cell type to the next. So when it changes, it's called metaplasia, and then when it becomes pre-cancerous, then it's called dysplasia, and that's where you're changing from your natural cells to cells that are more concerning to develop into cancer in the future.
And how is this treated?
So the initial treatment, if you have Barrett's esophagus, is most of the time now it's called radiofrequency ablation, and it's with an endoscopy, and we basically ablate or burn the edges of the lower part of your esophagus, just the inner layer where that cell changes is happening, and it causes that to scar down and gets rid of those concerning cells. Now this is not necessarily going to cure your reflux, but it will take care of those cells that are worrisome in the future that you're going to develop something. So after you have this done, you still need to be screened in the future every year with the EGD to make sure those cells don't come back and you don't develop worsening cell changes in the area.
There is a link between GERD and esophageal cancer. What is that link and how serious is it? How much of a cause of concern?
So once you develop Barrett's esophagus, it's a concern. If you're not to that point, then there's no way to really say there's an exact number or percentage you're at risk. Once you develop Barrett's esophagus, you're about a 0.5 to 1% chance to develop what's called adenocarcinoma or cancer of the esophagus throughout your life. The medicine does not necessarily prevent that because, like we said, you still can have the silent episodes of getting the reflux and damage. And so the reason that now we're looking into it more is that over the last like 30, 40 years, the incidence has increased like 400% as far as esophageal cancer diagnoses. And that's around the same time that the proton pump inhibitors started to become more of a thing. Just take this every day, you'll be fine, it gets rid of your symptoms. So we're basically doing symptom relief, but not necessarily treating the problem that's causing the symptoms. So you may be on a PPI for 20 years and then all of a sudden you get screened and you have a small esophageal cancer and you thought, well, I was treating my reflux. Well, you were controlling the pain symptoms that you were having, but you weren't necessarily preventing the damage from occurring.
There is a device that can help with GERD, and in fact we're going to take a listen to a patient's story right now and see how this device has helped at least one Ochsner patient.
I was having a lot of gastric reflux, and I couldn't, every time I ate, everything would come right back up. I was unable to eat because nothing would go down. Everything would back up on me, just like a funnel. I could take a couple of bites of something and it would just start backing up. I would go to sleep at night. I would have to sit up on a bunch of pillows. I mean, and it just got worse and worse. And so my sister had seen Dr. Delahoussaye on TV, and she sent me a text, and I said, well, I'm going to go see him. Made an appointment to go see Dr. Delahoussaye, and he took some tests and found out that I had gastric pheresis. We fixed that problem, and it didn't correct the gastric reflux, so I went back to him. And what happened was I had a hernia, so he did a hernia repair, and he also put the links in there. This definitely changed my life. I was told that after I got the links, I would have a problem swallowing food. For me, it's just the opposite. I don't feel like the food is getting stuck anymore. Before, I used to choke on water. I could take 3 swallows of water and it would overflow like a funnel. Now I can just swallow water all at one time and it don't even overflow. It just goes down real smooth. And I have no more gastric reflux at all.
Good for her. And doctor, what is that device? And you brought it along with you, right?
Yeah, so the device is called a LINX device. So what it is, it's a magnetic ring. It is made of metal, and the way that it works, we put it around the esophagus basically to create a new lower esophageal sphincter. So it stretches, opens and closes. So during the surgery, I put it around the esophagus and then clamp it together. And then you can see it's about the size of my finger. And then when you eat a meal, it'll open up like that. And then it'll close, and it applies just enough gentle pressure to prevent the reflux from happening, which is more of a passive process. And so the pressure is enough to prevent the reflux, but not too much to where it's not going to allow you to eat or drink something.
The incision is happening where? And talk to me about the procedure.
So it's a laparoscopic procedure. It's usually 5 incisions. So you get a few small, like less than 1 centimeter incisions, and then 1 incision at your belly button that the device goes through. So incisions are similar if anybody's ever had a gallbladder surgery or an appendix surgery, very similar looking incisions to that.
Any dietary restrictions? Is it like bariatric surgery in that regard or no?
So not from this. So usually I tell patients they need to eat soft foods every few hours, and that's so that we can have the device open and close We don't want it to scar down very tightly. We want it to form a loose scar so that it opens and closes and does what it's supposed to do as far as preventing the reflux.
All right, thanks. Dr. Tommy Delahoussaye, thank you for your education and for your work in the Ochsner Health System. To make an appointment with any Ochsner physician, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen or send us an email. And here's our address, hellohealth@ochsner.org. Always looking for ideas, too. As a reminder, you can rewatch this week's presentation and many of our other Hello Health programs on Ochsner's website at ochsner.org. Just type Hello Health in the search area. Our thanks again to this week's guest, Dr. Tommy Delahoussaye. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is reserved for you for your support of this program, Hello Health. I'm Tom Bagwell. We'll see you right here next time.